Alright guys, this should be our last recording to kind of finish up our lecture. So let's quickly jump into oxygen saturation. This is one of the not quite as common vital signs that a medical assistant may get, but sometimes you will. So let's talk about it. This is the oxygen content of the blood. A normal reading would be 95 to 100%. So that's the amount of oxygen within your blood circulating around. When someone needs to be put on oxygen or to use some bronchodilators to open up their airways is when our oxygen saturation is less than 90. So between 90 and 95, we're going to try and tell the patient to take a deep breath, see if we can get them there. And sometimes patients that have like COPD, emphysema, they may live at like 92, 93, and that's okay, and they might not need oxygen. But once you hit 90, you have to start doing some type of intervention, putting them on oxygen, something like that. Now, let me just point out, you as a medical assistant cannot put a patient on oxygen. It is a prescribed medication, so a nurse or physician would need to do that. But you would need to make someone aware, hey, this patient's oxygen is 89%, it's 90%. What do you want us to do? Can you take over? That kind of thing. And then at 70% and lower, it's life-threatening. Their organs are gonna start shutting down because they don't have enough oxygen to help power those processes. So it's reported as SpO2, and you find an oxygen saturation using a handy-dandy pulse ox or pulse oximeter. These can be placed on the fingertip, as you'll see here, but you can also have ones that actually have a sticker that can go on your forehead or around your earlobe or even across the nose. But the most common place is on the tip of the fingernail. And then sometimes you'll have women with fake nails, lots of fingernail polish on it, and this actually can affect the reading. So you'll need to remove any fingernail polish if you're going to use that fingertip. Okay. So just to hit on administering oxygen, when we don't have enough oxygen, our body starts going into hypoxemia and there's damage to vital organs. I kind of mentioned that already. But so it's important that if someone's oxygen's too low, to put them on supplemental oxygen. It's prescribed as a flow rate, so 2 liters is often a prescription for oxygen, a flow rate. And as I kind of mentioned, it's ordered in liters per minute. So a patient might go home on an oxygen tank and they'll have 2-3 liters of oxygen as needed or something like that. But just note that that's how it is administered and delivered. Briefly talking here, there are different ways to administer or methods of oxygen delivery. You'll see here we have a nasal cannula. This goes up the nares and around the ears to hook on. Stays nice and tight in our nasal area here. And this is best for if you have 2 to 4 liters of oxygen. Now, if you need higher levels of oxygen, you're going to use a plastic disposable mask, a partial non-rebreather, a rebreather, or Venturi mask, and there's some pictures of these. Again, you don't need to be an expert on those, just know there are different delivery methods for oxygen because you as the medical assistant will not be placing a patient on this oxygen. But you may see some of these items in the clinic. All right, visual exams. So often following obtaining vital signs, you will be asked to obtain visual acuity. And so these are some things that we'll practice in class as well. But it's important to measure visual acuity at many different ages in life because for kiddos, we want to make sure that they are seeing well. They may need glasses at a young age. My son does, and he's only 4. And then as we age, our eyes get tired and we need a little extra, maybe even just reading glasses. But it's important to measure our visual acuity. The physician may use an ophthalmoscope to visualize the eye. And we will use visual acuity charts like the Snellen chart. That's what this chart is here. And you guys probably never knew what that was called, but have seen it many times. It's actually called a Snellen chart or a Jaeger chart, which is this little chart here. And you might not have ever seen a Jaeger chart, but actually tests near vision, whereas the Snellen tests distance vision, so far distance. And then Ishihara plates are these plates here, and they actually test color blindness. So watch these videos, very important. We will also be practicing using the Snellen chart in class. Just like we check the eyes, we may also check the ears. So for a physician, you may hand them an otoscope, and you've probably had your ears looked at many times, but that's what an otoscope is. They use that for the ear. So ophthalmoscope for the eye, otoscope for the ear. And they're looking at many different aspects of the ear, and you'll see here they're looking in the middle and the inner ear using that otoscope. And you may test hearing using an audiometer. Please watch this video. It's important to know the medical assistant's role with the audiometer. They will be the ones actually using it and assessing the patient. You'll get more training in person when you get hired on as a medical assistant, but know that you may be using this type of equipment to assess hearing. All right, so the last thing that a medical assistant may be kind of tasked at doing following vital signs is obtaining an electrocardiography or electrocardiogram, also known as an ECG or an EKG. And this is a graph that represents our heart's electrical activity. So it's telling us how the electrical current is running through our heart, and it's produced through those impulses. The reasons we get ECGs or EKGs is we want to make sure that the patient's not having a heart attack. Maybe they come in complaining of chest pain. We want to get that ECG so the provider can read it and see if they're having any type of myocardial ischemia, which is short, or just the medical term for a heart attack. We can also estimate if there's been any past damage to the heart, if there's any type of cardiac arrhythmia, if we may also want to see the effects of a cardiac medication. So maybe they've been on a medicine for atrial fibrillation, AFib. We want to make sure that it's working and that the patient is no longer in AFib. It can also tell us a little bit about electrolytes. If a patient's potassium is off, it can sometimes be shown on an ECG. So lots of different reasons that we obtain these graphs. Very quickly here, I want to talk about the cardiac cycle and kind of describe what's happening on this graph. No, you'll not be the one reading it. You won't be interpreting these ECGs, but I think it's important to kind of wrap your mind around what it is that's actually showing up on this graph. So kind of putting two and two together. So a P wave. Our P wave is when our atrium, these top parts of our heart, are contracting. And so this is called atrial depolarization. So this is atrial depolarization. It's when our atrium are contracting. It causes this little P wave on our graph. Then we have what's called a QRS. That's that big spike. And this is our QRS complex. And this is when our ventricles, that's the bigger part at the bottom of our heart, contracts. Okay? So the atrium contract, and they actually relax too, the atrium relax, but it's kind of swallowed up by the QRS, so you don't see it represented on the chart. So P wave, the atrium contract, QRS, the ventricles contract, so that's called ventricular depolarization. So atrial depolarization, ventricular depolarization, and then lastly we have a little T wave at the end, and that's when our ventricles relax as well. So our atrium contract, causing the P wave, our ventricles contract, causing the QRS, and then the ventricles relax, causing that T wave. And that is what we call our little PQRST, our little cardiac cycle, and that's one of those. And it'll show up, that's our normal sinus rhythm, that's what we want to see on our ECGs. There are different types of ECGs. We have a single channel electrocardiograph, and this is where you have to get each lead one at a time. Much more time consuming. We don't have a lot of these anymore. What you'll most likely be using is called a multi-channel electrocardiograph, and it records several different leads at one time. So that sounds confusing. Again, we'll be practicing this in class. It'll kind of make more sense when we're actually using it. But I just want to jump ahead and show you what it looks like. So we obviously need our ECG paper, that's that graph paper. We need an electrolyte. This is what actually is kind of stimulating that current through our body. Sensors or electrodes, and these are what are actually hooked up to the patient, so like those little stickers. A lot of times now that electrolyte and the sensor are a 2-in-1. So we'll put a sticker on the patient and it has that electrolyte inside. So it's just a 2-in-1 kind of thing there. And then the lead wires. So it's called a 12-lead ECG, but there are only 10 leads actually attached to the patient. So actually only 10 spots that we hook them up to. And then of course we need the ECG machine as well. So let's talk about where we put those 10 stickers or those 10 leads on our patient. So we have 4 limb leads. So one on the right arm, one on the left arm, one on the right leg and left leg. So that's 4 of them. Those are easy peasy, right? Then I'm going to jump ahead and show you where these other 6 are placed. So you see here we have the right arm, right leg, left leg. Then we have V1, it's the 4th intercostal space on the right of the sternum. V2 is on the 4th intercostal space on the left of the sternum, so they're right across from each other. And remember, intercostal is the in between each rib. So 1, 2, 3, 4. 4th intercostal space to the right and to the left of our sternum here. We then jump to V4, and we actually place it on that 5th intercostal space in mid-clavicular line. Anybody remember what is also located there? Our apical pulse. That's where we find our apical pulse. So we put that V4 lead there. Then we go back to V3, and it's directly between V2 and V4. So it's kind of an easy spot, just boop, right in between it. Then V5 is at the level of V4, so right beside it, but at the anterior axillary line, so in the front of the armpit. And then V6 is at the same level of V5, so right beside each other in a straight line, but it's the mid-axillary line, so actually be up inside your armpit, so kind of on the side of your body here. Okay, again, we'll be practicing this in class on actually how to put those leads on and where to put them. All right, just note here that you may detect some arrhythmias on your ECG. The most important thing is just to note what is normal, and anything that is abnormal, you go and get a provider and show them immediately. You do not need to know how to interpret ECGs, but it will be important for you to know what a normal one looks like, and anything other than that, you go get somebody. All right, lastly, and very, very quickly, as we're running out of time, we've gotten our patient's vital signs. We've done some of those tasks kind of early in the visit, gotten their visual acuity or hooked them up to an ECG, and now it's time to put them in a room and get them ready for the provider. So it'll be your job to position them and drape them appropriately. So making sure that they put on a gown and put it on the correct way. So in the ER that I work in, we have our patients open their gown in the back. But if you work in an OBGYN office, they often have the patient open it in the front so that they can do a breast exam or a genital exam, whatever they may be doing. So be sure to help them in any way. Some of our elderly patients may need help getting undressed, but obviously note that a healthy 20, 30-year-old may not need any assistance. So at that point, leave the room. But let them know what's expected and what's going to happen next. So some positions just to be familiar with here to position your patient, because it may be important to go ahead and get them in a specific position for the provider to go ahead and come in and do their assessment or procedure or what have you. Supine, you're laying on your back, and kind of think of supination, like soup, holding soup in your hand. Pronation, you're going to flip on your belly, or prone is the position name. Dorsal recumbent position, you'll see here, is when you're laying on your back with your knees bent and up. Knee to chest position. Lithotomy, often vaginal exams done this way. Sims position. This is called Trendelenburg. Patients that are in shock or have low blood pressure are often put in this position up on their head so that we get blood to our most important organs, which are our brain and our heart, right? So we want the blood to rush there. We don't really need it in our toes as much as we need it in our head and our brain and our heart. Semi-Fowlers here, and then high Fowlers. Patients that have some respiratory issues may need to sit up in that high Fowlers position to get as much oxygen as possible. And then lastly here, there's some positional and directional terms. You should be fairly familiar with these, having taken your medical terminology classes, but just to familiarize yourself with some of these terms, as I will be using them in class. So read over those, again, familiarize yourself. And go back, read your PowerPoints, be sure to read your chapters, and good luck on your